Hi there everyone, my name's Lucas and I'm here to talk to you about kidney stones or nephrolithiasis today. So let me just move that. What are kidney stones? So essentially they're formations of crystals in the urinary tract and they can form anywhere from the kidney to the bladder and they can become lodged causing obstruction and they may be symptomatic or asymptomatic. So consider this sort of clinical scenario. You're the Gen Surg SHO on call and your reg bleeps you saying he's in theatre about to do a lap appendix. However, he's asked you to clerk a patient in the surgical hub. And you're given the following details of a fictional patient. So you've got Mr. David Samuels, his date of birth is 10th of the 4th, 89, with the following hospital number. And he advises you that the patient may have renal colic. So Mr. Samuel says, my GP sent me up here because of this awful pain in my back. And his obs on admission are, he's slightly tachy with a heart rate of 106. Blood pressure is 154/86. Rests are 20. Sats 97 on air. And he's apyrexial. So if you just pause now and have a think, what are the initial sort of differentials that are going through your head of lower back pain? So obviously they've mentioned renal colic, but have a think broadly about what else it could be at this stage. In terms of the history, so this is what's going to help differentiate between your diagnoses. You've got site. So typically with stones, it's a right or left-sided loin to groin pain. It's acute, it's severe, it's sharp and shooting, and it radiates to the groin or genitalia. It's important to think about alternative diagnoses in this case with the genitalia, so things like torsion is an emergency you don't want to miss. So something to think about there. In terms of associated symptoms, so you've got sort of general abdominal nausea, vomiting, and some GU things. So hematuria on the dipstick is very common for stones. And of course, as we said before, testicular pain is an important symptom and important to rule out torsion there. They can also have dysuria and frequency. Timing's important, so they can have sort of colicky symptoms if it's more of a chronic stone or constant, and that usually, if it's constant, lends itself towards an obstructed stone. Exacerbating factors, there's nothing really in particular. Other than you will probably recognise this patient as having renal colic by the fact they're not staying still. They're sort of pacing around the room in pain and very uncomfortable. Relieving wise, NSAIDs are usually the drug that helps. Particularly PR diclofenac is very, very effective. And obviously it's a very severe pain, as we've said. So far you've got a 34-year-old man. He's got right loin to groin pain, came on suddenly. It's sharp and shooting. He's got nausea but no vomiting, and the pain's getting worse. Pain relief hasn't helped at all, really, and he's in 10 out of 10 severe pain. And don't forget to do your systems review as well, but for him it's unremarkable. Now, if you'd like to pause again and just have a think, what are some of the risk factors for kidney stones? What sort of simple things can you think of that can increase your likelihood of developing them? And sort of at this point, I'd like to encourage you, go back through the history, past medical history, drug history, family history, because you can see and pick out different sort of risk factors just from that. So pause this slide and have a look through and see if you can spot any. So some risk factors, some common ones that I've highlighted here, mainly poor fluid intake is a massive one. Most of the time, this is what kidney stones are down to. And you can sort of reduce your risk a lot by a better fluid intake. But other things, modifiable risk factors, things like hypertension, smoking, diabetes, obesity, and gout as well. So gout in particular can cause urate stones in the renal tract. A good sort of statistic to quote to your patients is that if you have a kidney stone, you're 15% more likely to have another one in the same year. And that increases to 50% over the next 10 years. So quite high statistics there. You then move on to your exam. So your general abdominal exam finds a soft abdomen, but tenderness in the right flank, or the renal angle, as you'll see it sometimes quoted as. There's no guarding or peritonism, which is an important finding, and there's active bowel sounds present. So Mr. Samuels asks, what happens now? So how would you investigate him, and what would you manage as a result of those investigations? So I like to split this into three sort of clear sections for my investigation, so I don't miss anything. But from the bedside, as we said, you want to do a urine dip, particularly looking for hematuria. Pregnancy test, if female, always do a pregnancy test with abdominal pain in young women of childbearing age. And an ECG is sometimes done in the surgical hub as a baseline. Laboratory-wise, you want to do your basic bloods for abdominal pain, and then a coag and a group and save, especially if you're considering surgery. So it's useful to just do them all in one go. A lactate is very important, just to look at things like sepsis. So these kidney stones can cause infection, causing sepsis. In terms of your imaging, gold standard is a non-contrast CT-KUB, and that's because stones are opaque, so you don't need contrast to see them. You can also do an ultrasound KUB, and this is more for the younger pregnant population who you don't want to irradiate, but this is still sort of user dependent for the radiologist, and it's more sensitive for hydronephrosis, so it's slightly less ideal in certain situations. So from the tests, you get urine dip back with lots of blood, normal ECG, normal bloods, and on your imaging, you get a right-sided, non-obstructed 4mm stone in the pelviureteric junction. So that's what you've got back. So in short, the management is refer to urology. However, we're going to delve into a little bit of what they do on the next slide. So what then happens to Mr. Samuels? So on the left side of the screen, you've got your sort of acute management of renal colic. And in this case, with a small 4mm non-obstructing stone, you can consider discharge with a trial of analgesia, hydration, and tamsulosin, and that's an alpha blocker which can help decompress the renal tract and help pass the stone. This is because we can consider discharge in this case because it's a small stone, so usually less than 7mm, and it's non-obstructing. It's in a non-obstructing position. Follow-up scans need to be arranged within 4 weeks, 4 weeks later to check the stones passed. So that's what's done in this patient, and you obviously give safety netting. However, with Mr. Samuels, he comes back 2 weeks later with worsening pain and now a fever, and this is his CT-KUB. So have a pause and have a look at this scan here, see what you find. The management of stones is based on three main factors, so pain, obstruction, and infection. So we know he's got pain. On the scan, he's got obstruction with evidence of hydronephrosis, which is just swelling of the urinary tract. And he could have worsening renal function and anuria if very severe, but that's usually quite rare. Infection-wise, he's feverish, so we need to look out for things like sepsis. Your acute management for an acutely unwell patient, as always, is an A-to-E approach, and in this case, the sepsis 6, as he's got a fever, and he may have signs of sepsis as well. And obviously, call for senior help if you're a junior, and get their assessment and input. Medically, you want to give antibiotics and fluids if they're shocked, and analgesia. Ultimately, surgical management is going to definitively manage this patient, so you need to refer to a urology, and that will be for decompression, usually the same day or within a couple of days, and that's via a nephrostomy or a stent or PCNL. And that PCNL I'm not going to go into for the scope of this lecture, but that's for staghorn calculi, one to look up in your own time. Urgent decompression is needed for an infected, obstructed system, so these are patients that can become very well very quickly. So this patient here, Mr. Samuels, is at risk of that with feverish, when he's feverish and obstructed. Sort of long-term prevention, we sort of mentioned the risk factors earlier, is aimed at hydration. So you're aiming for urine that's sort of straw-coloured or less as a guide for your patients, but that's usually around 3 litres a day. And then the lifestyle factors and diet need to be addressed also.